of tissue injury and inflammation and fibrosis and so on. MR elastography is a widely available method for evaluation of fibrosis. Here we have stiffness maps for subjects with different fibrosis stages, where you can see how the stiffness increases, increasing fibrosis. Here's a study that used both MR elastography and chemical shift encoded fat quantification longitudinally to follow patients, so before and after treatment. And here's an interesting study where just the PDFF appears to have some value in distinguishing those who are going to respond to treatment and those who are not going to respond to treatment. So basically, those for whom the PDFF in the liver declined by 30% relative, so like if you're at 15% PDFF, 50K is down to 10%, that was pretty predictive of histologic response and NASH resolution, so with odds ratio around 7 and 5.5 respectively. So pretty interesting that just change in fat is predictive of changes in the other histological features. Recently, there's also been heightened interest in liver T1 mapping in the context of NASH. So this is iron-corrected T1 map from a paper a couple of years ago. And the iron-corrected part really comes from the fact that iron deposition in the liver affects T1. So if you measure T1 as a marker of fibrosis, you really want to do something about the fact that there might be iron there too. So here's an example of this T1 or corrected T1 maps where the T1 value goes up with increasing fibrosis. And so this T1-based method has been proposed and actually commercialized as an approach to detect fibrosis or actually fibroinflammation. Because one limitation or one challenge of these methods, particularly T1, is that it's not that specific to one particular histological feature. So fibrosis, it's sometimes referred to as a marker of liver badness in the sense that it's related to fibrosis and inflammation, but nonetheless, it may have value in the context of NASH. Now, in the MRI community, people always like to measure multiple things at the same time, so this is a really cool work from one of the students at the University of Wisconsin doing T1 mapping jointly with PDFF mapping, and also with R2-star, again, a marker of liver iron concentration. There's a number of these works out there, and they may have value in the context of comprehensive evaluation of liver health, maybe for NASH. Okay, but just going back to the big picture, we want quantitative imaging biomarkers that are comparable, that if you get measurements across different centers, vendors over time, that you can compare those measurements, just like in the case of the blood analysis. So how do we make this happen? So one approach is to standardize, to harmonize the data across different centers, and the other complementary approach, so not exclusive, is to develop methods that are highly reproducible. So if you change your acquisition parameters, you still get the same measurement. So for example, if you do MOLY T1 mapping in the liver, and you acquire with different parameters, so for example, different echo times, then if there's no fat, then you can have pretty reproducible T1 measurements, even if your echo times are different. But as there is more and more fat, your measurements become poorly reproducible as a function of your acquired echo time. So of course, this is a problem if you have different sites using MOLY T1 mapping with different echo times. Here's another example for ADC mapping that goes back to Dr. Denis' presentation just a few minutes ago. So diffusion MRI has also been proposed as a marker for fibrosis in the liver. This is an old paper, but it really makes the point where you have all these values acquired in patients with different fibrosis stages vertically and with different choices of p-values horizontally. And the interesting thing, or maybe a little scary thing, is there seems to be some ability to distinguish fibrosis stages based on the diffusion signal. So there's a range, a monotonic relationship between ADC and fibrosis stage. But that range is smaller than the range of values that you get in the same type of patients just by changing the p-value. So in the context of ADC mapping for fibrosis assessment, you really want to make sure that you use the same protocol, at least the same p-values if you want to compare across studies. This is the PFF repeatability and reproducibility in that same meta-analysis by Takeshi Yoku that showed really good repeatability, really good reproducibility across magnets, and field strengths, and acquisition parameters. So these encouraging results led me to come up with this very, very ad hoc subjective plot of where these techniques lie in the context of measurements being relatively insensitive to acquisition parameters. So PDFF and R2 star, you can change your echo times, you can change your spatial resolution within some range, and you're going to get very comparable measurements. Whereas things like MOLY-T1 or ADC in the liver, you really need to keep your acquisition parameters constant if you want to achieve comparable measurements. Now that doesn't mean that these more reproducible methods don't benefit from standardization, which they probably do, but perhaps the need is a little bit less present. So going back to where the blood sampling or blood testing world is, there's these guidelines for clinical laboratory improvement amendments in the US that have written policies and procedures, highly systematic quality control tests, at least daily, and then they have these proficiency tests where basically an external agency will send some challenge samples to the labs for analysis. We have nothing like this in the context of MRI, but I would argue that we probably should have something like this. What we do have is some initial attempts like the RSNA-Kiba profiles, so these two are relevant to this discussion as of December 2023. So liver MRE is at the more advanced stage 3, clinically feasible stage. PDFF is a little bit behind at the consensus stage. However, these standards are way behind the laboratory standards. And one thing that the community should probably do is move closer to having more strict, more highly controlled quality assurance and standardization of the acquisition and processing of these methods. Okay, that's all I wanted to say. So just to recap, this has been an exciting year for quantitative MRI, particularly in the body. There has been a lot that has been accomplished, but there's a lot left to do, and we need help. We need more reliable quantitative methods that work every time in all patients. We need to move towards improved standardization. And finally, there's a lot of fascinating biology and clinical outcomes questions, particularly in the context of the new drugs that are coming out, that we can maybe start to answer with these quantitative biomarkers. Thank you.
Thank you, Dr.